Hi, this is Brian Kim. I want to share with you case number 254 in the Best Way to Do Cataract Surgery series. This is a dense cataract, and you're going to see this patient also has some severe zonulopathy. So I'm going to employ a no rotation lens disassembly technique to minimize stress on the zonules. There's a lot of people who have cataract surgery techniques that are dependent upon a loose lens. And so therefore, when you encounter zonulopathy, you're really stuck because you have to spin the lens and you have to exert stress on the zonules. Well, if you can learn and develop no rotation lens disassembly techniques, this will be much better for these situations. And then on top of that, I'm going to place a capsular tension ring, and you can certainly put in the capsular tension ring whichever way you want, but I also employ a minimal stress capsular tension ring insertion technique. And what I do is I hook the leading eyelet with a Lester hook, and as I deliver the capsular tension ring, it causes the capsular tension ring to stay in a smaller size diameter because I'm using compression forces to restrict the opening of the capsular tension ring with that leading eyelet, and thereby minimizing any torsional stress on the zonules. So you can see here this patient has a right eye, and there's quite a bit of a Bell's reflex on this patient, and I'm trying to turn the eye down, and then I'm using the corneal mark, which will help me to center and size the rhexis. And this is my paracentesis incision, first on the right side. And then I'll have to ask the patient to look all the way down. The patient's having some trouble with that strong Bell's reflex. Ask the patient down, immobilize the eye with a cotton tip, and then I make the paracentesis on the left side. Holding the eye with a cotton tip, and then switching with the cannula, injecting intracameral epinephrine, and then some dispersive viscoelastic. And I had to hold the eye because of this patient's strong Bell's reflex. With that cannula still in the eye, I make my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. And keeping that same OVD cannula within that incision to keep the patient from rolling the eye up from the strong Bell's reflex, I go ahead and switch to the microrhexis forceps. I puncture the center, pull down. I'm trying to gently sweep and grab that right side of the tear. It's not behaving quite normally, again, which is a sign of that zonulopathy I was talking about. And as I'm doing the rhexis, you can feel some zonular laxity. And so all throughout the case, you're being mindful of all these things. You should have a feel for how the lens is behaving. And so as I'm pulling to do the rhexis, I could sense that it's requiring more effort. And as I'm pulling on the rhexis, the lens is kind of giving way and it's stretching the zonules. I'm being very mindful, very careful to exert as little stress as possible while executing the capsular rhexis. Finish off the rhexis, burp some viscoelastic out, and then I have to come out of the eye, and of course the eye is moving wildly. I ask the patient to hold it still, and this is the capsular fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally. Get a nice wave. Lift the lens up, decompress the bag, and push the lens back down into the bag. Being very careful here, I just don't want to cause any more zonular stress, so I just decide not to spin the lens at this point. Irrigating the surface of the eye, adjusting my sleeve, lifting the incision with a chopper, go in with irrigation off to minimize Descemet's trauma. Removing the surface epinuchal material. As I do this, look at the wobbling of the lens. That wobbling of the lens tells you very clearly that this patient has quite a bit of zonulopathy. So I said, okay, I'm not going to take a chance here. I'm just going to go ahead and sculpt the trough. Give myself a little bit of a competitive advantage. Go ahead and just sculpt, remove, and debulk that dense central core. As I'm sculpting and making that trough, look at how much wobbling there is of the lens. Again, further evidence that this patient has zonulopathy. Going down and sculpting. And once I'm good with that depth, I switch to quadrant mode. I place the chopper under the rhexis edge contra-incisionally, hooking the peripheral lens, placing the phakic tip deep in that trough and fracturing the terminal side. That is a terminal chop technique. fracturing and propagating that chop all the way through. And now I have two complete independent heminuclei. Trying to slide that chopper under the rexus edge, under the right heminucleus, but look how much wobbling there is of the lens. So I'm just trying to be very mindful, because if I try to push the lens, it might wobble, but I was able to get all the way around it and then go ahead and execute the cross-chop maneuver, fracturing that right heminucleus in half. Using the chopper and the vacuum to grab that first quadrant up and pull it up out of the bag, and then using mechanical forces to disassemble that first quadrant. Very carefully trying to separate that second quadrant from the rest of the lens. You can see it is separated, but they're just kind of jigsawed together. Placing the chopper under the right quadrant, trying to separate it again, didn't quite work. Trying to lift that second quadrant up with the chopper, again, it didn't quite work. Turning the chopper sideways now, and as I did that, it caused the second quadrant to roll up. So the posterior aspect kind of rolled up, and I was able to then pop it up out of the bag and take it out. So that was cool. I just turned the chopper sideways, and that allowed me to cause that second quadrant to roll and then come out of the bag. Using some vacuum to lift that second heminucleus up out of the bag, getting the chopper around it, and then fracturing it in half. And then using mechanical fracturing forces to crush the lens into smaller pieces, and then emulsifying the lens piece. Lifting the last quadrant up out of the bag with vacuum, and then using mechanical fracturing forces, crushing the lens between the instruments, and then emulsifying the lens pieces. So again, turning the chopper sideways was what allowed me to get that second quadrant up. I was not able to hook the lens from the top. The lens kept rolling out, that second quadrant, and I wasn't able to lift it up out of the bag. So getting it sideways and pushing, and it caused that second quadrant to roll out. So I removed all the epinucleus here. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I'm using that cannula, the BSS cannula, to hold the eye. Again, this patient has a strong Bell's reflex, and I'm using that cannula to hold the eye as I do INA. You can see there's a thick epinucleus, which is fine, and I'm peeling from anterior to posterior, being careful using foot pedal modulation to very carefully and in controlled way remove that epinucleus. So the epinucleus has been removed. You can see there's like a thick cortical shell on the capsule, but look, as I try to grab it, look at the bag. It's so unstable. It's so unstable. And so it's not a good idea to go after this in cortex mode. And there's basically almost like capsule fibrosis, posterior capsule fibrosis. But again, if I try to grab that piece up, look at what's happening. It's just puckering up the posterior capsule. Again, this patient has somewhat of a rather loose bag. And I'm just trying to figure out what else I can do to get that material off the posterior capsule. So I said, instead of trying to pulse, I think that's not a good idea. I just go straight with the cohesive viscoelastic cannula. I feel like the BSS pulsing would cause more stress on the zonules. And then this is CTR. I'm placing the hook pointed down on the left CTR eyelet, hook down, and when it goes in, it rolls in counterclockwise so it can come out clockwise. Lift the incision with the Lester. I'm going to hook the leading eyelet with the Lester, and as I deliver it, I'm able to keep the CTR wound tighter in a smaller diameter, which minimizes stress on the zonules, and then I'm able to deposit each eyelet within the bag. Really a nice technique and something that I employ on every single CTR that I do. This is an older case. Obviously, you can see I'm widening the incision now. I prefer not to widen incisions anymore. What I like to do now is, If I know I'm going to use a bigger lens, like a 3-piece lens or something like that, what I choose to do is go with the larger incision as well as a larger sleeve. So I go ahead and widen the incision, but you can see it's not the most controlled way to make that incision. It's a little bit tight, but I'm finally able to get it in. This is a 3-piece lens. You want to have the bevel facing to the left. The leading haptic goes into the bag. I kind of pronate my hand so that the optic comes out nice and straight. Trailing haptic comes out of the eye. Go ahead and use the Maltzman to dial the trailing haptic into the bag. Now you will see that this patient has that posterior capsule material. I'll call it posterior capsule fibrosis, but I'm not sure if it's really fibrosis. But it's so stuck to the capsular bag, and whenever I grabbed it with vacuum, it just puckered up the entire bag. Not really worth the risk. But now that the CTR is in, I'm going to go in with polish mode and see if polishing the posterior capsule is something that I can do. But as you can see, it's still puckering up the capsule quite a bit. And it's not really worth trying to do that. This patient's going to have to be resigned to the fact that they'll have a little bit of PCO right after surgery and probably end up doing a YAG capsulotomy earlier than later on this patient down the road. You can see here, I got a little clear edge. I'm trying to peel it off, and I'm trying to peel it off, but again, not quite convinced this is the best use of my time, and you don't want to really cause any more trouble. But as you can see, I'm perseverating and really trying to clean that posterior capsule. Having that CTR in does provide some equatorial support, so I feel pretty good about that. And very carefully, I'm trying to clean off that material, but you can see it's puckering up the posterior capsule quite a bit. Using foot pedal control and in polish mode, very carefully and very slowly, I'm trying to peel that material off the bag. So I've gotten quite a bit of it off, not all of it off. You can see there's so much stria within the bag. And just, again, diffuse zonulopathy. In my experience, again, when you have dense cataracts, oftentimes they go hand in hand with zonulopathy. So at this point, I said, okay, I've done as much as I could. Put the lens back into the bag, switch to visco mode, removing all the viscoelastic from the anterior chamber, and then I will hydrate my incision. So again, this patient had quite a bit of zonulopathy, evidenced in the very beginning of the case when I was doing the capsular rhexis. As I was pulling the rhexis, you can see the bag was moving a little bit lacking counter resistance. As I was doing the rhexis, that means the zonules are loose or lax. And then it was difficult to rotate the lens after hydrodissection. Again, another sign. And then as I'm disassembling the lens, as I was sculpting, you saw how much the lens was wobbling. As I was using vacuum and aspiration to remove the epinuclear material, you saw the lens was jiggling wildly. I was able to sculpt, perform terminal chop and then cross chop techniques. Again, using mechanical fracturing forces to disassemble the lens. Turning the chopper sideways, I was able to plop that second quadrant up out of the bag. By rotating it, posterior part kind of popped up out of the bag. And then using vacuum to grab that second heminucleus, and then again, leveraging mechanical fracturing forces to crush the lens into smaller pieces and emulsifying it. And then using that minimal zonular stress capsular tension ring technique by hooking the leading eyelet and then compressing the CTR while it's going into the capsular bag, and then finishing off the case. So I hope this was helpful to you, and I thank you for your attention.